So just to talk about the balloon itself, I think most of us are using this balloon now very frequently as we handle more and more complex interventions. So just to talk about this balloon has got a very low lesion entry profile. The folding technology is better because, when we use this first generation balloon, I at least had 2 shaft ruptures when I went up to 45 atmospheres. The shaft, the lesion did not give up. The pressure back was so much that the shaft got ruptured. So now, the second generation balloons are very good. They have got a dual folding and tri-folding technology. There are dual platinum markers, so the visibility of the balloon is very good. Then double layered for double power, so you can easily go up as much as 50-55 atmospheres without being worried about it getting artery getting perforated. So indications for OPNNC balloon, ultra high pressure balloon is heavily calcified lesions, resistant or undilatable lesions, instant restenosis. It's rare, but whenever you get, it's worthwhile using this balloon in combination with rotablation, post-dilatation of stents, and CTOs. So as you all know that as we handle more and more complex intervention, imaging is being played a very important role, especially for calcium identification. I'm not going to go into the details which is better or which is not good, but as long as you have some imaging modality in your lab, it's good because this decides which kind of modality to be used. Now for debulking, we have so many modalities, so doing a small imaging before doing anything would be very beneficial. Why do you do that? So absence of intravascular imaging may lead to underestimation of calcium. We have seen that. I mean, we have been doing cases before the imaging came, and now we are so dependent on the imaging that it becomes difficult to handle these cases without imaging. So when you have an absence of intravascular imaging, you underestimate the calcium. Once you underestimate the calcium, your vessel preparation is not proper. So now what we talk about is adequate vessel preparation before the stent is implanted. When the stent is implanted, nothing else you can do. If the stent doesn't expand, then you're in big trouble. So all of this have got a very wrong and bad adverse outcomes, and this will lead to stent underexpansion, increased risk complication, longer procedure, stent malopposition, and maybe additional stents. So current treatment approach of calcium is our conventional NC balloons. We can go up to 30 atmospheric pressure with those balloons. Cutting balloons are, we had a lack of supply in between. Now Wolverine is there. Excellent balloon which is trackable. Scoring balloons, yes. I would say they are shade better than NC balloons, but not as good as cutting balloons. Atherectomy device, rotablation is there with us for last 3 decades, so that is still playing a major role for us. So tools of block modification according to the characteristics of the pathology, what you see in imaging. If it's soft, fatty, then non-compliant balloon. Fibrocalcific, you can use cutting balloon and scoring balloons. Calcific, now we have, at least we have rotational atherectomy. We don't have orbital atherectomy as of now. So rotational atherectomy is a mainstay, but somehow this device has remained in the hands of less people because of the steep learning curve. So what is the need of an OPNNC balloon is this. If you understand the dog boning which happens over here, we have all seen that, and we keep on going high pressures to remove the waste. What happens is, in this kind of situation, when the center of the balloon does not open, there's a high pressure created at the edges, and that sort of either ruptures the vessel or causes longitudinal dissection. Whereas in OPNNC balloon, the amount of pressures you can go up is very safe, and it has got uncontrolled radial and longitudinal growth so that the balloon expands well, and easily you can go up to 45-50 atmospheres and then take away the waste. So problem with incomplete expansion of the stent, as we discussed, is the stent when it's implanted in an underprepared vessel, the elution of the drug is not proper, and that can give rise to a risk of instant restenosis and high risk of long-term MACE. There is no comparison between OP-NC balloon, rotablator, and cutting balloon. I think, there's no one over here to replace anybody, but I think they're complementary to each other. Many of these cases, we use all three modalities together, and now IVL is also is used quite frequently. So just to highlight about OP-NC balloon, its ease of use. It's a slightly bulky balloon, so we advise at least you need to have like a support wire so the balloon navigates easily. Suitable for all kind of calcific lesion. There's a less procedure time, there's a low learning curve, and you get better stent opposition if you use it for post-dilatation, lower inflation time and lesion dilatation, and lower exposure to radiation. So save your time and reduce radiation. One balloon does the full job. You can use it for preparation of the vessel and for post-dilatation. That's what we've been doing most of the time. So these are some tips I would like to share with you. So according to the company IFU, the product IFU, if you see, they say that you should avoid this polymer jacketed wire, polymer coated wire like Fielder XT or Whisper. But I don't think so. It's a hard and fast rule. You can use it on any wire as far as you're comfortable, but preferably use on a support wire because the navigation of the balloon is an issue and it's a bulky balloon as you all experience. So they say use support balloons, support wires most of the time. So for pre-dilatation, use 0.5 mm less. If your reference vessel diameter is 3 millimeter, so use 2.5. But for post-dilatation, you have to use 1:1. So this is the kind of situation, and we all know that there's a inflation device comes with it, which can go up to 55 atmospheric pressure, and increase the pressure gradually after reaching 20 atmospheres. Can you take this off? Excuse me? There is some, okay. So tips and tricks, these are some of our own tips and tricks, plus I have gone through the literature and found out this. So downsize the balloon diameter by 0.5 compared to the intended stent size. As I told you, if it's the proximal LED is 3.5, so use a 3 mm OP-NC balloon. So go gradually. So you go up to 20 atmospheres, wait for some time. For every 5 atmospheres, wait for 1 second in between so that you transmit the pressure to the tip of the balloon or to the middle part of the balloon. De-air the balloon properly. So that should take some time. You should de-air this balloon. I mean, not like IVL, but this is at least you little bit de-air with the syringe. Inflate the balloon up to 20 atmospheres and wait for 5 seconds. The pressure at the manometer is not immediately equal to the pressure of the balloon. So give it some time to transfer the balloon to the distal part of the balloon. Observe the fluoroscopic appearance of the balloon. If it's not expanded, increase the pressure stepwise to 25, 30, 35, 40 and go up to 50. Wait for 5 seconds in between. OP-NC safe balloon at high pressures. Perforations are almost not reported in this. Vessels are ruptured by too large balloons and not by too high pressure. Once the balloon has fully expanded on fluoroscopy, hold the pressure for 5 seconds. You may need a gentle increase in pressure after that. Deflate the balloon and wait for 5 seconds because the balloon takes some time to double wrap itself. So don't immediately pull the balloon after deflating because then you may end up, guide may get sucked in and your ostium may get dissected. I'm going to end with the last 2 slides. So this is one of our patient. I just took a snapshot of this. Heavily calcified proximal LED. OCT showed severe calcium, almost 360 degrees. Vessel diameter was, OCT was showing 3.5, took out 2.5, went up to very high pressure. Dog boning was seen, went up to almost 45, 50, more than 40 atmospheric pressure, and then repeated an OCT. And you can see the cracks over here, which are very well visible. And then this, we were able to put in a stent, 3.5 Zan stent, and deployed and post-dilated with the NC balloon. So as you can see on the right side panel, an excellent result. So I conclude my talk saying in patients with complex calcified lesions or undilatable lesions, ultra-high open balloon plaque modification device dilatation followed by stent implantation can achieve maximal luminal gain for short-term and long-term outcomes. Thank you very much.